Thanks, Steve. Great. I think you have to give me permission to share the screen.
We can do that. Let's see here. I think, Deidre, are you the host? Oh, hey, yeah, you have the, there you go.
Okay, that's not it. Let's turn. Are you, all I have is the picture of you guys.
We can see your one of your PowerPoint slides.
You can?
Yeah, and
great.
yeah, you're on like slide 45, so you have it up.
Now, which one are you seeing? Are you seeing the regular screen?
Yeah, just the yeah, not presenter view, just the slideshow.
All right, let's get back to the beginning. All right, here we go.
Yeah.
So these are my disclosures. None of these are relevant to the talk we're going to have today. But the talk is based upon many publications out of the International Spine Study Group. These are just a few of them. But this group of about 30 surgeons, both open and minimally invasive, have published literally dozens of papers looking at many aspects of deformity surgery. And this talk is based mostly upon the data that came out of that group. Today, I still think it's the case that open correction of adult deformity remains the gold standard. But over the last decade, many techniques have developed to accomplish deformity correction using minimally invasive or hybrid techniques. And the data that's been collected suggests that less invasive surgery offers multiple potential advantages to open surgery in deformity. And we know that the standard list of advantages of minimally invasive surgery, that there's less blood loss, a lower infection rate, less stress response, intensive care is either eliminated or shortened, hospital stay is minimized, we utilize less medication for pain, the recovery tends to be faster, and we have decreased soft tissue destruction. But there are also several potential advantages that are specific to deformity surgery. For example, can we decrease the number of levels that we fuse an instrument and get similar results? Can we lower the incidence of proximal or distal junction kyphosis? And can we decrease the cost of these surgeries? As we all know, deformity surgery is very costly. And then there's other questions we can ask as well. Will minimally invasive surgery decrease or increase complications in deformity surgery? And can we correct sagittal deformity in minimally invasive surgery? And can we do complex cases, or are we limited to just the very easy cases if we're going to use minimally invasive technique? So say, for example, this 75-year-old woman comes to your clinic. She is now a retired nurse. She has a 47-degree thoracolumbar coronal cob, which is offset partially by a 21-degree fractional curve and a 13-degree thoracic curve. And you can see that her thoracic curve is secondary and that it bends out pretty well. So her major problem is just that the thoracolumbar curve. Now, if we're going to do her minimally invasively, we have to be able to use the same techniques, be able to do the same thing we do in open surgery. And that means either we do multi-level interbody fusion between T45 and T12L1, and that is usually done through a lateral approach. Over the years, I've learned that doing an anterior approach, an ALIF at 4.5 and 5.1, is better than doing laterals at that level, because at the bottom of a very long construct, the size of a cage that we can put in through a T-lift just isn't large enough to give you a high fusion rate when you're doing deformity. We want to make a midline incision, but we only incise the skin. The muscle stays intact and we dilate through the muscles. So we need to be able to do percutaneous pedicle subtraction osteotomies Smith-Peterson osteotomies, facet fusions, and we need to be able to do percutaneous screws and a percutaneous subfascial rod passage, all in minimally invasive technique, which would be the equivalent of what we would do it with open surgery. So if I haven't done an ALIF and I'm doing this purely laterally, I will start in the lateral position. I will position my patient on a beanbag. I use a thoracic arm support to hold her arm up. The reason I do that is the arm and shoulders will bend the upper body to the ventral side, and that will change the orientation of your vertebral bodies and give you a different approach. So I don't want that to happen. So I use an arm support. I tape the patient to the bed. Now, we all know that when you get into surgery, the first thing your nurses do is they come and put a towel over the patient where you're going to put your tape so that you don't tape to the skin itself. And that does a really good job of holding the towel in place. But if you have to airplane the bed, your patient's going to fall off the bed. So I throw the towel on the floor and I put the tape right on the patient's skin to hold them in place. And we use a bean bag, which holds the lower portion of the body. We crack the bed just enough to open up the space between the lower rib cage and the iliac crest. And then if we need to, in order to account for rotary scoliosis, we will airplane the bed so we get a perfectly lateral approach to each of the vertebral disc spaces that we're working on. I then use fluoroscopy to mark where my incisions are going to be. I want my incision to be right over the middle of the disc space that I'm going to be working on. And that means that in rotary scoliosis, the incisions may actually change their location on the skin. Once that's made, I make my incision. I used blunt dissection using retractors or my finger to define the retroperitoneal space and to get down to the iliopsoas muscle. It's very important. Two steps are very important at this early stage of the operation. The iliocostalis muscle lies somewhere between the external oblique and the internal oblique. If you use bovie cautery and cut that, or if you use sharp dissection and cut that, your patient will get a flaccid abdomen and they may get a burning dysesthesia in their scrotum and penis or vagina. So it's very important to do that bluntly and not injure that nerve. The other second very important thing is to visually inspect the lateral aspect of the iliopsoas muscle so that you know that you don't have any bowel stuck to it. There have been several cases where the dilators went right through the bowel and in some cases caused death of the patient. That is particularly true in rotary scoliosis. So it's extremely important to actually visually inspect the entire lateral surface of the iliopsoas muscle. Then after you've done your dilation, I stimulate through the muscle to make sure that I'm not going to be injuring the femoral nerve. And when I know that I'm in a good place, I enter my stimulator into the disc space. And as you can see on the left there, that's about where you want it. You want it just off midline ventrally. After that's placed, I place a K-wire through that stimulator and then dilate over that so that I get a good dilation. Now, there are many retractors available, and I've used many of them, and I've gone back to my earliest and most simple dilator, which was the Medtronic dilator. And the reason for that is this was designed so that once you're in place, it can never move. It doesn't give you much versatility except cephalad and caudal. But you put the K-wire in, you put the dilators in, and then you put your retractor in place and put screws into the vertebral body above and below. It cannot move, and you know that you are where you intended to be with your original lateral fluoroscopic image. Other retractors that I've used, for example, this retractor is very versatile, but the problem is it can get you in trouble. For example, in this case, this was locked in place here, which was about where we wanted. But when we wanted to give ourselves more room, we expanded ventrally. And now you can see that our ventral exposure is actually ventral to the vertebral body. So when I put my cage in, it's not going to be completely in the vertebral body. It's going to be partially outside the body. So I've stopped using these very versatile retractors. I've gone back to the simple retractor where I know that I'm going to be safe 100% of the time. On this image, you can see a partial discectomy done. You can see the radicular artery going right alongside it. After your discectomy is done, you can prepare your cage and tap your cage in using AP fluoroscopy to get it directly in the midline. As you can see, this patient, we did a 4-level approach. All of these are very nicely positioned. This is a little bit posterior, but it's fine. In this case, we did not have to do 5-1. Her find one was good. She had a rotary component, so in order to get all of her levels, we actually made 2 lateral incisions to give us directly lateral approaches to her disc spaces. And you can see they're all really pretty nicely ventrally midline placed. So that takes care of our lateral part. And then we have to go to our posterior part. Now the posterior part is going to be a combination, in this case, as you can see, a T-lift. This was early on before I switched to A-lifts. And facet fusions above the level of our interbodies. So we're now in the prone position. We make our midline skin incision. In this case, I was doing a T-lift. Today, I would probably have done an A-lift. And then you can use image guidance or fluoroscopy to pace your K-wires or instrumentation, whichever you're comfortable with. I'm still using just standard fluoroscopy. It's very, very fast for me, very easy. I place all of my K-wires in the AP, and then I change the rotation to a lateral on one time, and I advance all the K-wires through into the vertebral bodies. But you can do this under whatever technique you are most comfortable with. Once your K-wires are placed, you can do your dilation, and your tapping, and place your percutaneous pedicle screws, all of which you can see here using a variety of different systems. And in this case, with that same patient we just showed you, she got an excellent coronal and excellent sagittal correction. You can see all of her staples here. This patient had had a previous nephrectomy. We still came from the same side in order to do her interbody fusions. So that really did not interfere with this operation at all. One of the comments I've heard is that this is very interesting, but it's really of no application in scoliosis surgery. And then I always think back on some of the famous quotes that turned out to be tremendously hindsighted. And, Marshal Ferdinand Foch said, airplanes are interesting toys, but of no military value. So our early data, we looked at our patients and compared their radiographic results and their clinical results after either minimally invasive hybrid or a standard open adult deformity patients. So we looked at their radiographic and clinical outcomes, and our criteria were greater than 45 years, a lumbar cob of greater than 20 degrees, and 1 year minimum follow-up post-operatively. It was a retrospective review of prospectively collected data. Open surgery is your standard operation that we all know of, that our orthopedic colleagues typically do for scoliosis, and that is it's all done posterior primarily. It's a completely open procedure where the muscles are completely dissected off the spine. Osteotomies are then done. Interbody is then done through a T-lift or a P-lift, and posterior instrumentation is done. Minimally invasive is the technique that I described to you earlier, and a hybrid technique does a minimally invasive lateral or anterior approach, but the posterior instrumentation is done open. So we looked at coronal cob angle, sagittal vertical access, lumbar lordosis, pelvic incidence, and pelvic tilt. And our clinical parameters were oswestry and a VAS. So this was the first series of patients we had done. Now this data is just of my patients and my colleagues' patients at Northwestern when I was there. And what we found was that using minimally invasive technique, we were able to correct cob angle equally or even better than open technique. And the reason for this, I think, was because we were using the lateral approaches to interbody, whereas very few of those were done using the open technique, and they relied solely on posterior osteotomies and instrumentation. However, our lordosis was not as good as either the open or the hybrid technique. Our change in degrees was only about 5 degrees versus 17 degrees in the hybrid. Now 17, remember, hybrid is using a completely open posterior technique. That translated to the pelvic incidence minus lumbar lordosis degrees. Early on in our series, we were not doing a very good job of correcting that. And in fact, if we looked at SVA, we got virtually no change whatsoever. However, if you look at their preoperative SVA, it was already normal. So we were not looking to change the SVA in these patients. Despite that, however, despite not correcting our sagittal angle as good as open or hybrid, our clinical results were equal to or better than either the hybrid or the open technique, which raises an interesting question. How important is correction of sagittal balance? So we looked at that more closely. And what we found was that in young individuals, it is very important to get good correction of sagittal balance. Their clinical results were not as good when we did not get a good correction of their sagittal balance. But in individuals over 65 years of age, it didn't matter anymore. And that was one of the lessons we learned, that in a 65-plus-year-old person, sagittal balance isn't between 0 and 5 degrees anymore. It's more like 0 to 10 degrees. Aging is a kyphosing process, and our body wants to be a little bit more kyphotic, whether we like it or not, as we age. So sagittal correction in the elderly is not quite as important as it is in the young individuals. So one of the other comments we hear too is that, minimally invasive surgery for scoliosis is no better, and it's a lot harder. And I love the quote by Dr. Forrest that man will never reach the moon regardless of all future scientific advantages. So what does that quote tell us? Is that you never know what's around the corner, and we keep advancing scientifically and medically, and eventually we're going to be able to do the things we never even dreamed of. So is it better or not? Well, in our first series, we reduced our blood loss from 2 liters to 500 cc's. We've gotten better over time. Our average blood loss now for say a T9, a T8 to S1 fusion is 200 cc's. So we've also decreased our transfusion rates early on from 80%, above 80% to about 30%. And now I would say our transfusion rate is 15%. The operative time is about the same as open. Hybrid took much longer, surprisingly. Our complication rates, we decreased from 45% major, not overall complications. Overall complications in the open group were 90%. 45% were major complications. We dropped that to 10%. And I would say we're probably doing slightly better than that now. So is minimally invasive correction of deformity better than open deformity? Yes. Is it harder? As you're learning it, yes, it is. But there's no question that it's better. How about our question of whether we can shorten the constructs of our correction if we're doing minimally invasive surgery? So in our ISSG database, we looked at over 1,200 patients, and we propensity matched them for preoperative radiographic measures. And then we looked at our postoperative results in looking at that group. What we found was that for the minimally invasive group, we fused approximately 5 levels. In that same propensity matched group for open surgery, we fused 10 levels. So the average interbodies were basically 4 versus 2 for open. Our blood loss was less than 1/3. Our hospital stay was 2/3 of the open procedures, but there were no significant differences in our clinical outcomes. So yes, we can fuse many fewer levels in minimally invasive correction of deformity than we do in open deformity. I believe the reason for that is, as in all minimally invasive surgery, we are not affecting the adjacent levels. The adjacent levels to the end of our procedures are completely normal, whereas in open surgery, they're denervated and they're devascularized. So we also looked, however, at proximal junction kyphosis and distal junction kyphosis following open and minimally invasive surgery. This study by Praveen Mumaneni showed no difference in the incidence of proximal junction kyphosis. In a secondary study that we did looking at distal junction kyphosis, however, and there was only a very small number, I think there were about 15 patients in each of these propensity matched groups, we did not quite reach statistical significance, but it was very close. And the suggestion is, in a larger cohort of patients, I think we'll demonstrate that there is a lower incidence of distal junction failure in minimally invasive surgery compared to open. And as you can see, it was 15% versus 31%. So what were the, our possible advantages that we looked at? Did we decrease the numbers of levels fused and instrumented? Yeah, by about 50%. Did we lower the PJK and DJK? I think the results of that are still coming in. We don't really know the answer yet. And did we decrease cost? That's coming up. So the next criticism we've had, and what I showed you in our early studies, was that we didn't do a very good job of correcting sagittal balance. So the question is, can we correct sagittal balance? And two major changes have given us the ability to do good correction of sagittal balance. One is hyperkyphotic cages. In our original studies, we were using either hyperlordotic. We were using either 0 lordosis or we were using 6 degree of lordosis. 6 degree of lordosis isn't really hyperlordosis, that's normal lordosis. So we weren't really using cages that corrected lordosis whatsoever. Some of our cages now go up to 30 degrees of lordosis. The second thing that happened was what we call the push-through technique. When we're doing minimally invasive deformity correction, we are using towers that had a limited ability of space to pass the rod. And that's usually about 6 to 8 centimeters, which means if you do a hyperlordotic bend in your rod, you're not going to be able to get it through all of your towers. You can get it through the first and second, but third is difficult, fourth is impossible. So we were limited to doing a very gentle lordotic cage, which meant we weren't really correcting lordosis, particularly at the lumbosacral junction, very well. What we figured out we could do, though, is use a long rod and do a very gentle lordosis, so we could pass it through all of the towers. We would start proximally, and we'd pass it all the way through the distal end, and then we'd push it out of the wound of the last one, and then we would do our hyperlordotic bend. Now we don't have to worry about passing it anymore. All we have to do is pull it back into the rod and lock it down with our set screws. So there's our hyperlordotic bend now, which you can see that would never be able to pass through all those towers with that hyperlordotic of a bend. And then we pull it back and we cut the other end of the rod off. So for example, in this patient who came in with a visual analog back score of 8, and this is this patient's T2 sagittal MRI. We did stage 1 was a L5S1A lift with 15 degree cages. We then did L lifts at L2 through L4-5 with 10 and 20 degree cages. And then we did anterior releases with the 30 degree cage at 3-4, and then posterior percutaneous screws. And you can see we didn't have to do very many levels to really get this patient very nicely corrected with an excellent SVA, so excellent sagittal correction. And she reduced to a level of a 3 back pain at 1 year. When we look at this now, so this is just the results of the push-through technique. You can see we're getting excellent change in SVA, excellent change in lumbar lordosis, and excellent change in our pelvic incidence versus lumbar lordosis. And in fact, change pre-op to post-op was significantly different for all of those, for lumbar lordosis, for pelvic incidence, and for pelvic tilt. So the question is, are we limited to doing very simple cases, or can we do really complex cases that we otherwise do using open technique? So in our group, we've created what's called the MISDEF algorithm, and this is intended to help people decide what kind of technique they're going to use to do their correction of lordosis, of their scoliosis. So in this case, if you have an SVA of less than 6 centimeters, so a simple, very little correction needed, pelvic tilt less than 25, mismatch less than 10, and minimal olisthesis, then we can do a completely minimally invasive procedure. If we have that same preoperative radiographic deformity, but we've got greater than a 20 degree Cobb angle, experienced minimally invasive surgeons are still going to do it minimally invasively. Less experienced will probably go to an open technique or a hybrid technique. If they don't have a flexible curve, if they've got a mismatch greater than 10 but less than 30, thoracic kyphosis less than 60, it's kind of a hybrid technique. Again, advanced minimally invasive surgeons will do it minimally invasively, but particularly if they do not have a flexible curve, it's recommended to do it completely open with osteotomies. So this is what we recommend, but I'll tell you quite honestly that for experienced minimally invasive deformity surgeons, this is already outdated. So for example, let's take a look. This is again one of the simple cases, except it's already got this huge olisthesis here. So this would be recommended either for a hybrid technique or an open technique, but it can be done completely minimally invasively, giving an excellent sagittal balance and excellent correction of the coronal cob angle. Well, what about some more complex cases? How about a case of a rigid thoracic kyphosis? Now, we said rigid cases should be done open, but this patient has obviously a huge rigid thoracic kyphosis, which was nicely corrected and giving him good sagittal balance. This was an individual, excuse me, who trains people how to drive buses in Chicago. And he was not able to do it because of his pain, and he was able to get back to doing that job within 6 months. This is an 18-year-old college basketball player who has this, again, fixed rigid thoracic kyphosis. He got an excellent both coronal and sagittal and went back to playing collegiate basketball. How about rigid double major curves? So here's a young woman with a very rigid, almost 60-degree thoracolumbar curve, compensated by a rigid 56-degree thoracic curve. And you can see these are very rigid. They don't bend out at all. Nonetheless, using completely minimally invasive technique, we were able to get her an excellent correction both coronally and sagittally. 48-year-old male with the same kind of problem, 45-degree rigid thoracic curve, compensated by a 45-degree lumbar curve. Very nice coronal with excellent sagittal balance. Here's a really challenging case. Not only does she have a severe thoracolumbar rigid curve, but it's also coronal. You're almost looking at the sides of her vertebral bodies here. She got an excellent both coronal and sagittal correction. If you look closely, you can see here that this screw is actually not in the vertebral body. In the correction, we actually fractured right out of the vertebral body. The strength of the rods in correcting this is so strong that it ripped right out of the vertebral body. And we took her back and took that out. And you can see she had sort of abnormal anatomy. This is an S1-2 A-lift. So we did S1-2, 5-1, 4-5, and 3-4 A-lifts in her. Very interesting case. Well, what about rigid thoracolumbar kyphosis? Can we correct that very well? This is an individual who came in not too bad in his coronal balance, a little bit of scoliosis, but he's got a 35-degree rigid kyphotic angulation. This is a patient that I see in my local restaurant every other week, and I obviously really wanted to get a good result in him. And as you can see, we got excellent correction of his coronal balance and really good correction of that thoracic kyphosis. So can we decrease complications in surgery? Can we correct sagittal deformity? Can complex cases be done? I think we've answered all of those, and we've answered them all positively. So in summary, correction of deformity using minimally invasive techniques is a reality for most types of scoliosis now, particularly for experienced surgeon. The technology and experience are still early in development, and as we gain experience and figure out better technology, we're getting better and better at this. The anticipated benefits are clearly proven at this point in terms of less blood loss, less infection rate, less hospital stay, lower cost, better correction, good correction of sagittal deformity, and maybe lower incidence of distal junction kyphosis. So although the results are still early, they're very encouraging. In our current stock market, this is something to keep in mind. Stocks have revealed what looks like a permanently high plateau, right? So what about our other improvements? Our hospitalization is decreased by almost half. Our cost, just in looking medical costs, not rehabilitation, comparing open to minimally invasive, per case is $122,000. If we look at rehabilitation, it's less by $8,000. So we're looking at a total of $140,000 per case decreased cost to the hospital. So as we know, minimally invasive surgery, although 25 to 30 years old now, is still evolving. More and more of our procedures are becoming more widely done by minimally invasive surgery. Early on in my career, it was called minimally effective surgery. And we were called, I can't remember what they were calling us by some of the open surgeons, which was a relatively derogatory term. We probably shouldn't be saying it in public anyway. But I remember William Osler saying, remember, the philosophies of one age have become the absurdity of the next, and the foolishness of yesterday has become the wisdom of tomorrow. So never sell short what we're going to be able to do tomorrow, because we're very creative individuals. And when we see a problem and we see that it has to be fixed, we somehow figure out a way to fix it. So there's no question in my mind that over the coming years, almost all surgery is going to be done minimally invasively. We will get to a point where, for many cases, open surgery will be below standard of care. Thank you. I'll be happy to answer any questions.
Thanks so much, Dr. Fessler. That was great. I remember some of those techniques during fellowship. For some of those rigid cases that you showed, it seems like, the MIS technique really relies on the power of the inner body space, compared with some of the traditional open techniques. Is it mainly that, and then the rod contouring enabled, basically bringing the spine into alignment on the rod? Well, for some of those tougher cases?
For the rigid cases in particular, you're going to want to be doing multiple level facetectomies. Between the cage will give you your height and correction of some of the rotational deformity, mostly correction of the coronal deformity, and the facetectomies free up the movement of the spine enough so that when you put the rods in and do your correction, that it'll come into alignment. There's another tricky technique I use to help with that, and I think you've seen it, Zeev, is that I use a double rod technique, and that is I will pass the rod bilaterally through all of the pedicle screws, but then I pass a second rod through the tower on each side. And particularly if you use a fixed pedicle screw rather than a universal head, between the two, so a point is a point, 2 points is a line, but 2 lines is a plane. So when you use 2 rods through a single tower over this entire construct, that really corrects your coronal deformity, brings it right into line.
Dr. Fessler, this is Martina. Thank you for your talk. Very inspiring. I have a very practical question, and the MIS work I have done with the different skin incision. Every tower gets a skin incision post-operatively. That's sometimes not very aesthetic. And I'm wondering, for your long instrumentations and lung cases, do you make still one midline incision, or do you still do separate stab incisions? How do you do that so you don't have like this gazillion incisions in the back that run into each other in variable angles?
Yeah, hi Martina. Yeah, I make just the one midline incision, just the skin, and I dissect the skin out about 3 centimeters so I can then dilate through the fascia. And I totally do that for cosmesis, because it looks much better than the multiple stab incisions going up and down the spine.
Yeah, I have researched, I started doing this as well. Yes, so interesting. Feel very validated. Thank you.
Thank you.
Hi, it's Steve Papavasiliou. I got talked to you about a year ago. I wanted to, if you could comment on a couple of items, statements I noticed. One of them is, a few years ago, you would have done a T-lift. These days, you'll be doing A-lift, which I found myself to be doing as well. Can you elaborate a little more into that? I know you mentioned in the beginning of your talk, but I would like to hear your side. Why are you doing more A-lifts now than you used to?
Yeah, Thanks for the question. Yeah, I found that I had a high 5-1 pseudoarthrosis rate when my lowest interbody cage was done through a T-lift. And it, the size cage that we can put in through a T-lift is so limited to about the size of our finger that it just wasn't enough. But it also helped that I have an absolutely brilliant general surgeon who does my approach. And I can do a 2-level, a 4-5, 5-1 A-lift in about an hour and 10 minutes, skin to skin. And that gives me a huge base for my long construct. And I no longer have that pseudoarthrosis rate at 5-1.
That was exactly my observation too. The pseudoarthrosis rate is so much higher if you don't go anterior.
Yeah.
That's what I had noted. And I make sure I have the good surgeon you do too.
Plus, it allows me then to put in, a 25-degree cage at 5-1 and
Right.
4-5. And that does 90% of my sagittal correction right there.
That's right. Great. My second question is about the age and the note that the sagittal balance is not as important anymore.
This is a very controversial topic, and especially open surgeons just will not agree to this no matter what. But our data is clearly showing that if I take a 65, 70-year-old person and I correct them to 8 centimeters rather than 5 centimeters, they do just fine. And in fact, it may be that when we correct them to 0 to 2 centimeters in that age population, that they have a higher failure rate because their brain is telling them to be slightly kyphotic.
I've noted the same. If I correct them really well, they don't like it. They're not happy, and I cannot find the reason.
And I think it's because, as we age, we become more kyphotic and our brain adjusts to that. And it's decided that's where we're supposed to be. And when we overcorrect them, it continuously tries to put us back there.
Thank you. No, that was great.
Dr. Fessler, for your distal stop point, I noticed that, with the MIS approach, you can, go down to S1 and feel quite confident, versus, the open approaches, you're going more down to the pelvis. Are you doing much, what I found here at BI, we have the robot and it's really good for S2 AI screws in terms of lining it up with the tulip heads. Are you still, are you kind of the mindset stopping at S1 is fine for some of these longer constructs?
I think it is, but I also have no objection to the S2 screws, the A1 S2 screws. I try and avoid going to the pelvis whenever I can.
Yeah,
that is so much more limiting functionally for the patient. But the AI S1 S2 screws don't do that. So
right.
That'll give you a little bit more. That's not really very strong bone, but it gives you a little bit more. And I think that's a good idea.
Great. Any other questions for Dr. Fessler? All right. Well, it was great to see you, and thanks so much for all your insights.
I'm happy to have been here. I don't think you told everyone. Did you tell everyone the story of what was going on this morning?
No, yeah. No, Dr. Fessler almost, he lives up north of Chicago in the suburbs, and on his commute down, he called me at like 5:30. There was like an oil tanker that had crashed on one side, and then there was like an 18-wheeler on the other side. So we were worried he wouldn't be able to make it and have to give the talk from his car, but but yeah, no, it was good.
All right, everyone. Thanks. It's great seeing you all.
Thank
I
you.
look forward to when we can get together again, and have a great rest of your week.
Take care.
Thank you, Dr. Fessler.
Bye-bye.
Bye-bye.
Bye.